So the session is started.
Give us a cue, or shall I start? Will give us a cue.
Yes, sir. The session is started. You can start.
Okay.
Yeah.
My dear friends and esteemed colleagues, it's my great opportunity to welcome to this great webinar the people across Pan India, Professor Dr. Venkatraman, Professor Dr. Sunil. It's a Pan India seminar and the large number of logins today. And in spite of three competing programs going on, I'm extremely happy to announce there is a Pan India webinar. And today we are extremely happy to welcome the delegates. We know they had different choice but have joined us today. That makes us feel great. Dear friends, no time in the history of diabetes than this time, which was more exciting than ever. The purpose for which we have met today are five. The objectives of this webinar are five. I'll just take 3 minutes to describe the objectives and then we'll pass on to the panel discussion. Dear friends, I'd like to mention this is a national webinar on the primary and the primordial prevention of diabetes, and we are going to give a balanced view. I don't believe neither me nor my friend, I'll just call my first name Venkat, nor Sunil, none of us believe that we should medicalize a term called pre-diabetes, because we don't medicalize a term. But I will unfold before you and why we are having this webinar. And this is a webinar, and the people who are the main heroes of the webinar are Dr. S. Venkatraman, the former professor director of the Department of Diabetes, both in Madras and also in the Madurai, now senior consultant diabetologist at the Apollo Hospital and the Surya Hospital. And the other expert is our also very dear friend, Professor Dr. Sunil M. Jain, from the most awarded city of the country, from the city of Indore. He is the consultant endocrinologist, MDDM. He's the his own center called the Total Diabetes and Hormone Institute Indore, which I visited more than once, and I must put my hand on the heart and say it's one of the best institutes for diabetes care, teaching, and research. So this evening belongs to these two people who are the heroes of this evening. Dear friends, why we're doing this? Is pre-diabetes a great burden in our country? Dear friends, if I can go back to previous slide, you will see, can I have the previous slide? The pre-diabetes is a great burden because of its huge prevalence. The type 2 diabetes risk, which lurks, and for us, for the Indian ethnicity, is much more. It is laden with complications, same complications as type 2 diabetes. And also, it is a part and parcel of the metabolic syndrome, the GDM, the PCOS, and many other conditions are HIP are the part of the syndrome. Look at the burden. Why we're discussing this today is the fact that, can I have the next slide? See the global burden and then see the Indian burden. You know, if you see in 2021, there was about 10.8% of the adult there are two components of pre-diabetes: impaired fasting glucose, impaired glucose tolerance. You know the definition. The blood sugar is between 100 to 125, and the postprandial is normal, is impaired fasting glucose, which is much more prevalent than impaired glucose tolerance, where the fasting is normal but postprandial between 140 to 199. Now, you know, there's 10.8% of the adults, 541 million, and the impaired glucose tolerance is 6.2% of the adult, 320 million. And you see the numbers, astounding numbers that will rise in the 2045. To make a long story short, I'll conclude by saying this particular objective of ours: that pre-diabetes is much more prevalent than type 2 diabetes, and hence today's discussion. Next slide. See the Indian burden. You see the Indian burden, you see, we had in 2011, we had 20.4 million of IGT, which has risen to 40.1 million in 2021, last year's IDF Atlas, and poised to become 50 and 65.5 million in 2030-2045. And if you look at the impaired fasting glucose, I said it is much more than the IGT. It was about 75 million in 2021, was to become 85 million. Therefore, my dear friends, we are discussing something which is more prevalent than type 2 diabetes. Second objective. Next one, please. The second objective is to make something very clear on behalf of not myself, on behalf of my very esteemed expert. We do realize that we do not want to make pre-diabetes a medical condition or don't want to help the drug pharma to sell their tablets. I agree with the article which was published in the Science in March 2009, which said that pre-diabetes is it a dubious diagnosis? Has it credited millions of new patients and a tempting opportunity for giving some them drugs? And they discussed the various aspects. But the next slide shows what the current status today. In 2021, there's a changing paradigm. Today, even in United States and the Europe, lifestyle is number one, number two, number three. Next, metformin has been indicated in primary and primordial prevention. Now, today, I think Sunil and Venki agree with me that ADA and the United States Public Health System has said that, that the screening has to be done. In 2022 ADA guideline, screening has to be done to detect pre-diabetes, and they have lowered the age to 35. It was 45 earlier. And lo and behold, like we used metformin from 1956, we were always saying that as a nation, from the very beginning, we advocated screening at the age of 30 if the family is positive, 35 otherwise, and we said that universal screening is our answer. So the second objective, that why we should screen, and the next slide shows. Can I have the next slide, please? It shows why we're discussing this, because diabetes is a progressive disease, a microvascular disease, neuronal disease, and that disease starts in pre-diabetes. The next slide, the last slide, shows that what I wanted to tell you very clearly. Can I have the next slide? This is the fact of the matter. Now the charge is, the bottom line is, in its consequences, pre-diabetes is simply early diabetes. You cannot separate. Am I correct, Sunil? Am I correct, Venki? And that is what Mayor Davidson, David Nathan, who are the people, they said today's diabetic management centers around the theme of early action. Early action. Am I correct? The first year diagnose, the first year control matters. So today we will discuss through these two extremely learned. I mean, I have selected them amongst many, and we had to postpone this twice because to get that time was not easy. So, how do we discuss? How do we diagnose? How do we screen? Are there any biomarkers? How do we risk stratify? And how do we treat this condition? Next slide, please. There's a slide where we are going to discuss today a very important concept, my dear friends. Those who have joined today, see, every type 2 diabetics, does he or does she passes through pre-diabetes? The answer is yes or no, but the answer is yes. Every type 2 diabetes passes through pre-diabetes. So, what is our ultimate choice? The choice which is burdened with us, the choice we can change, the imperative choice. The imperative choice, of course, is to prevent pre-diabetes going to full-blown diabetes. And that is not medication. That is lifestyle number one, lifestyle number two, lifestyle number three. And there are indications where we should give medication. So the way forward is the one which we'll discuss today. So, dear friends, the basic program is a panel discussion. So can I put the first question to my very dear friend Sunil, Professor Sunil Narayan? I'll call him Sunil after this. Sunil,
Yes, sir.
what is your opinion about the conversion rate of pre-diabetes to diabetes in India? It's a talk show, so we'll talk very informally, and the people are here to take notes from that talk. So it is absolutely a frank, free discussion, informal discussion. Yes, Sunil.
So, as you sir rightly said, that ultimately somebody with type 2 diabetes will be normoglycemic, and during that time we know that there is another pathophysiologic abnormality going on, which is right now not revealed in terms of glucose abnormality, but there is a insulin secretory abnormality going on. I can use pre diabetes for that. Then comes a stage when patient is having pre-diabetes, and finally many of them can get converted to diabetes. How many get convert? Now there are data. We have Indian data right from Chennai, which says that around we expect that around 60% patients are going to get converted from pre-diabetes to diabetes. And what is strange observation nowadays is if you look at the data of pre-diabetes to diabetes conversion rate 20 years ago, they were around 5% per year. And now, if we look at the recent data, the conversion has become more faster, drastic. It is now the newer data say 11 to 17% per year. That means now pre-diabetes is a important event where we are seeing a conversion also little faster than earlier. So obviously, a role of lifestyle would also be there.
I think it's a fantastic knowledge you have given us. We are converting faster today than 20 years before. This conversion rate is higher than the other ethnicity people, and any form of dysglycemia from normoglycemia can be found over a 10-year period in almost 60% cases. So that's a great knowledge. So the pre-diabetes can go back to NGT, which is very minimal in our ethnicity. It is much more we to convert to diabetes. That's a very important knowledge. Venkat, in today's age and today's day, how do we emphasize the importance of screening in India? You know, how do you emphasize? One of the objective of today's meeting, as I told, is to make the physicians aware that how pre-diabetes is important. You can put the pre-diabetes quote unquote, or you can call early diabetes important. How, as Sunil said, we cannot diagnose pre, but we have a way to diagnose pre-diabetes. So why it is important? Why screening is important, Venkat?
Thank you, Ashok. I think good evening. At the outset, I would like to congratulate the USV for two
Yeah,
things.
good.
For
They have done it.
entertaining a discussion on pre-diabetes, because I remember way back in 2011, if you remember right, I attended the first and second international seminar on pre-diabetes. I was told that this is going to be the last symposium because the nomenclature probably has been associated with some sort of a discomfort in the sense that the insurance and other legal aspects of the terminology.
Absolutely,
But
absolutely.
I think in the process, we have diluted the clinical connotation of prediabetes. It is a clinical entity, whether you could label it as a disease or a risk factor, I think it's the nomenclature that differs. And having said that, how do we start screening? I think the emphasis has been, even though the cutoff of 30 has been given by the ADA, I think quite a few of our colleagues have been good in screening people, even in say plus two at the primary, I mean school level, plus one, plus two, and colleges. I think this is where, especially with the family history of diabetes and obese children, now obesity galore across the young generations. So now even at the college, so probably what I do in my practice, I'll tell you, if the mother or the father or the grandma or the grandpa is being brought by a son or a grandson who is obese or, I mean, slightly overweight, I ask them to undergo a master health checkup. So, in fact, having spent some time with the patient that they have brought in for whatever meaningful consultation, so I would start that. You can start from anywhere. So, like we say in pregnancy, universal screening is a must, and the age cutoff given quite I mean, justifiably at 30 years. I think every window of opportunity, somebody gets admitted at 21 years, certainly you do your blood sugar. Of course, that will be a random. But to categorize them in a non-comorbid condition requires absence of infection, etc., etc. So I feel that yes, propagating the entity of of an abnormal glucose state, which is not necessarily associated with drug therapy, but it is associated with long-term complications. It is associated with a huge conversion, as Sunil just now mentioned, compared to non-diabetic. I think probably the conversion rate is about 3 times, and this is something huge. This is something huge, and of course, both IFG and IGT have to be there probably in the chronology of the events. IFG comes first because the liver is too excessively sensitive to insulin. So slight misattempt by the pancreas is reflected in the slight rise in the fasting blood sugar level. Even though many people across the world are not very comfortable in using this terminology, I think we believe that because we have seen a huge epidemic of diabetes and huge people. But only thing is, we in some of the tertiary centers do not have the opportunity to screen patients. Quite often they come to us with the advanced stage of diabetes mellitus. So I would like to say that the persons accompanying them could be motivated especially with risk factor like obesity, and especially a girl, a pre-marriage girl. I always say that it is probably cruel to put on weight, more for anybody, more so for a girl who is going, because they are going to be accountable for a subsequent motherhood as well. So these are the few thoughts that I have. Just
I think
any window of opportunity should be utilized, and then the person accompanying your patients can be the first target and motivated.
I think, Venkat, I cannot agree more. And you have addressed four things. Number one, you have said very categorically that pre-diabetes. What is there in a name? You call Sunil. Sunil will smell as fragrantful as a rose. Whatever name you give him. So whatever name you give it, pre-diabetes is important because that is the thing we wrote. Hyperglycemia is a continuous term, and any amount of hyperglycemia has endothelial dysfunction and has a worse or altered health outcome. Number two, today we know that early aggressive management of diabetes is important. If you do not use the term pre-diabetes, at least think it is early diabetes. Therefore, managing this, I don't say drug management. I'm saying about diagnosing and giving lifestyle is also extremely important. You know, there is a delay. It is a Europe study which just published, Venki Sunil. I had access to it because I reviewed that paper. That how much time one loses between onset and diagnosis of type 2 diabetes, not pre-diabetes, Sunil. 3 to 8 years. And in the 3 to 8 years, that's why they have given the percentage of complications. I read it out to you for the benefit of my audience. You know it. 8 to 16% at diagnosis retinopathy, 17 to 22% microvascular complications, 14 to 48% polyneuropathy. Macro is not seen, but this is seen. Now, therefore, there has been a study in UK who wanted to see the people who were from normoglycemia went to diabetic vis-a-vis people with pre-diabetes treated and anyway converted to diabetes. It was found that people who from normoglycemia went to diabetes at a gap of 3 to 8 years had these complications. In contradistinction, those quote unquote pre-diabetes, early diabetes, who were caught up as beautifully Venki said because of screening and were given management. It is not only drug, it is lifestyle, number one. And where necessary, in very clear cut indications, drug was given, they had less complications. So it has beautifully shown that today's world, in today's age, and today I use the word from that article, Venki, that today's world and today's age, the treatment of pre-diabetes, identification of pre-diabetes by screening is of paramount importance, and you have clear-cut guideline when to treat them and not to treat. Now, Sunil, I'll ask you, you know, what are the risk factors that prompt you to screen for pre-diabetes? And you say it for the audience benefit, one, two, three, four. What are the risk factors which make you screen?
So, as Dr. Venkat has already told, the family history of diabetes.
Good.
It's one very, very important factor, and particularly the first degree relatives. And if one or both parents are diabetes, it's very important that these are very high risk patients because they are born with that genetics. Now, secondly, how the lifestyle they adopt in the childhood, then that adds to the additional risk factors. Like those who put on a lot of weight, develop central obesity, develop marker of insulin resistance, those who develop hypertension, dyslipidemia, smokers. These are all patients in whom we have to screen. And then a subset of patient who comes from women's side. And that is what we know, that many patients because of insulin resistance develop ovarian endocrine abnormality, and in polycystic ovary syndrome with obesity also there is a big role. And those women who already had a history of GDM in past, obviously they are at a higher risk. So there is a big chunk of population who needs must be screened.
I think I will not repeat for interest of time, but everything he has covered from the endocrinopathies to the GDM, PCOS, and the obesity, sedentary lifestyle, very important positive family history. That is the reason. Do you agree when we wrote in the RSSDI guideline that, and we are campaigning for it, Sunil and Venki. We said pulse, BP, temperature, respiration. Let the fifth vital sign BA blood sugar. I think that's a great thing that we wrote, and it is going around the country. Whether it will be accepted, we have to see. Uh, I think Venki, I have a very important question. Are IFG, as you rightly said, a little bit shady, are IFG and IGT are two separate clinical entities? Do they overlap? Number one. Number two, what is the what is your opinion about using pharmacological therapy in the subject of prediabetes with multiple risk factors, such as the present of a, what Sunil said, strong family history, central obesity, he said, occurrence of both IFG and IGT, and of course the other comorbidity like GDM, past history of GDM and PCOS, etc. First, the between the IFG and IGT, are they separate entities? And number two, is there a overlap and the pharmacological management? Just initial thoughts.
Yeah, thank you. I think we did make a hint about it in the sense that having understood the pathophysiology of type 2 diabetes mellitus, insulin resistance starts maybe about 10 years, 15 years prior to the clinical onset of diabetes, and the process of compensation goes. So, this amount of extra effort by the pancreas is adequate enough to suppress the liver because the liver is excessively sensitive to insulin. And once that crosses the threshold, then probably the suppressive effect of the insulin on the liver is less. So the impaired fasting glucose is probably an earlier abnormality. Whereas advanced stages of the disease, wherein more insulin is required, probably is because you have to push the glucose even in the IGT range when you come to the impaired glucose tolerance, as Professor Ashok just now defined. When you give a glucose load, it is between 140 to 199. So, in the normal parlance, with a normal diet, you can expect the sugar to go up a bit. This extra amount of glucose is a strain to the cells because they have to metabolize the glucose. Some amount of oxidant damage can occur because the antioxidant capacity of the normal cells is already compromised. So, making a lengthy story short, IFG occurs earlier. IGT it signifies a later amount of the carbohydrate intolerance, and probably coming to reproducibility, an IGT is probably much more reproducible, and a reproducible IGT is probably a candidate for aggressive intervention, be with lifestyle as well as with drugs. Number one. Number two, IFG can, for example, you can have a fasting of 103 on one day and a 98 week later, especially when the patient realizes his sugar is probably in the borderline. So IFG and IGT are two entities, certainly, but both give the clinician an opportunity, not necessarily through drugs, as Professor Das repeatedly said. Yes, it gives an opportunity. Yes, look, be careful. You've got a family history. Your blood sugar is not in the diabetic range, but some of the values are in the range threatening to become a diabetic in the near future. So, lifestyle, and of course, with the drugs, we will come to a bit later. So, IFG first, IGT, and certainly a subset of patients can have both, which means it is much more in an advanced stage and they are more prone for developing diabetes mellitus. I think that's how I look at it.
Yeah, I think it's a great answer. You have given the definition of the both. What happens in both in a differential manner, nicely differentiated. Which occurs first, which occurs late. I think beautiful. I will not repeat it. I will not repeat any of the answers because they're so well self-explanatory. I have question to both of you. I'll start with Sunil, then I'll be switching to you. So, Sunil, what do you think? With the presence of a strong family history, and up type 2 diabetes, central obesity, occurrence of both, say both, somebody has both IFG and IGT, which Venki said is little advanced, not only IFG. Number two, the patient, you will prescribe what? Uh, as lifestyle, or you will prescribe lifestyle, then not working or not sufficient, switch over to tablets. What's your take on this? And what would you like to give the awareness to the physicians who have attended this meeting in thousands today?
So, if I diagnose a pre-diabetes today, number one, it's an opportunity to prevent the diabetes. That is fine. And the more important, in fact, it is the right time for intervention. Even we can do it early, but that is the point where we diagnose it first for prevention of cardiovascular disease,
Exactly.
because we understand that insulin resistance is one of the major culprit. So if we diagnose pre-diabetes in time, it's a very high time to act upon. for diabetes prevention and a lot of diabetes related complications, particularly the macroangiopathy prevention.
I think great. I think that's the greatest concept that I learned about few years back. Pre-diabetes is not only what we have defined; it also includes dyslipidemia. I'll give an example. People are starting practice recently. If there's an isolated hypertriglyceridemia, you can almost certainly say that he must be having diabetes. Dyslipidemia, hypertension, obesity, they are all the markers that the pre-diabetes does exist. So beautifully, Sunil said that he will definitely start them on therapy. It can be first as a lifestyle measure, and on a diet therapy, and if necessary, we'll come to that. Of there is non-adherence to lifestyle, if the lifestyle is not working, somebody asked how long you have to wait. So I checked the literature. They say 6 months, maximum 6 months. So wait for 6 months. The person is not able to do it, and you also find that there are a few other indications, like we'll come to that in a minute. So then only the indication for the drugs to come. Now I'll tell you that in your setup, Sunil and Venki, any one of you take first and second. How often do you find that in spite of advice that we give, we do not have the people to visit their house to do a calorie count? We don't have people to be talk to them every day on phone about the diet and take a diet recall. It has been observed that the diet therapy is costlier. That from the very various studies, DPP, DPS, and IDPP. What has been your experience that in what percentage of cases diet does work, and where diet is not enough? Diet works, but not enough, and we need something more, something else. Any one of you can start.
Yeah, thank you, Professor
Venki, you want to
Ashok.
start?
Yeah, yeah. In fact, before I answer this question, as a follow-up of what Professor Sunil just now mentioned, we are talking from the angle of carbohydrate abnormality with respect to the events, say cardiovascular. Now, I think Ramchandran and Satyamurthy did a wonderful paper. What they did was they had about few hundreds of patients with myocardial infarction who were not diagnosed earlier with diabetes. Most of them had dysglycemia, about 70 to 70%. Professor Ashok knows about that paper. It's a
I've
very
seen
good
that
paper.
paper. I've seen that paper.
Yeah.
I've seen
So
that paper. Then
two-thirds of
they
them
really
had diabetes. One third, among those who had dysglycemia, one third had diabetes, and two-thirds had pre-diabetes. See, this is the significance of a pre-diabetes, to put it in the proper perspective. Coming to the intervention, I am slightly biased with drugs, not because USP has sponsored this program. First of all, again, congrats for doing a program on metformin, because nowadays the fancy is to do on GLP receptor agonist, SGLT2, etc. Now, coming back to the main point, I believe that between lifestyle modification and the drug therapy, I would say that compliance with the drug therapy is much, much better than lifestyle modification, even though the DPP is there. All of us know that the failure for a mode of therapy when you start them on OHAs or insulin is the compliance, poor compliance with the lifestyle modification. In spite of all those things, having appreciated it, I feel that I would be too eager to start a patient on certainly lifestyle and metformin, even though the guidelines, of course, we are going to discuss about it later. I will be certainly make it a point. If the patient is not too keen, not force it on him, because he should not think that we are selling a product. After all, metformin is not that a great expensive molecule, and it's a wonder medicine, as we are going to discuss subsequently. And having proven in repeated trials that it has got the capacity to prevent diabetes. See, prevention of diabetes, I think, Professor Das, we should make it as it's a dynamic event. For example, you have a case of pre-diabetes. At the end of 1 year, what is the conversion? Then doesn't mean that all those who have not converted are not going to. No, it is going to be down the line. So that's what the DPP has told us. So coming back to the main question, yes, pre-diabetes has to be treated. Lifestyle modification along with metformin will be my choice for the simple reason I feel that to retain a patient on sustained lifestyle modification is extremely difficult, whereas retain them, good number of them on a molecule, especially a molecule which we are convinced has a definite say in the prevention of diabetes and the macrovascular disease, certainly I would start them on metformin.
Yeah,
That's
and
what.
a molecule which is cost effective, which is efficient, and without any side effect. Somebody has said, "What is the side effect of metformin?" They said it's compared to placebo. It is same side effect as placebo. So Neil would like to add something to what Venki has said.
Sir, the lifestyle modification as we were discussing, is it easy to implement?
No,
Like the trials when we talk, if we are doing a trial, okay, fine, we can do a phone call, diary, maintenance, so many things, and so many people involved. But does it work in clinical practice? I feel no. In clinical practice, okay, there are few motivated patients who are going to do it, but in fact, somebody who is already having IFG, IGT, lot of metabolic abnormalities, and parents are diabetic, already HbA1c has reached to 6.3, lifestyle obviously modification is very important, but it's very obvious that this patient is on the pathway of diabetes. And macroangiopathy as well as in future. So we should try to attempt to do best possible intervention, which should be pharmacologic as well as non-pharmacologic.
I think beautifully answered. I will summarize both the answers in single sentence. I've taken it from the 2020 diabetes care. It's from editorial of the diabetes care, which said, is prescribing metformin medicalizing, or is it absolute necessary? The opinion expressed by the editors in the article, taking cue from the M. Davidson's, he's a great man, M. Davidson's commentary, that it is not medicalizing. The prescribing metformin, and why not prescribe others? I'll come in a minute. Prescribing metformin is important. It is not medicalizing. It becomes an absolute necessity. So we'll discuss this further little later. So it's a great message to the people who are attending today. We are not medicalizing prediabetes. We are saying that the discussion that we had from the very eminent speakers, that it is not medicalizing, but it becomes an absolute necessity. Now, Venki, uh, now how does metformin address the underlying pathophysiology? We have something has been discussed like regarding the IR and all that, but would you like to add anything else? How metformin addresses the underlying pathophysiology of prediabetes?
Yeah, I think we did talk a lot about the insulin resistance. Yeah, I think in the pre-diabetic stage, in fact, I've been fortunate enough to be a PhD examiner for some of the students, especially from Ramchandran Center. A lot of people have done work on pre-diabetes. The inflammatory markers are increased, and so many other aspects. So when you talk about metformin, it addresses the insulin resistance. That's number one. Number two, how does it address the insulin resistance? Predominantly in the liver. So it is more a insulin resistance ameliorating drug at the site of the liver, which all of us know restraining the liver from producing that extra glucose probably will be the first step to prevent the dysglycemia from progressing. Now, having said that, how does it do in the liver? Now, can I just take an extra minute to talk about
Yeah,
some of the
please.
basic biochemistry? So, all of us know that glucose is metabolized. Up to the level of glucose to pyruvate, it is the cytoplasm. Then it goes to the mitochondria for the citric acid cycle and oxidative phosphorylation. Oxidative phosphorylation means pyruvate is converted to acetyl CoA, wherein some of the coenzymes are in the reduced form are converted to NADP, NADPH, etc., etc., and these have to be oxidized. If they are not oxidized, the term that we use is oxidative phosphorylation. That's what penformin was supposed to do. It's a wonderful molecule, provided
Yeah,
you obey the contraindications. Now, metformin is not been associated with oxidative phosphorylation, but what it means is in the metabolism of glucose to pyruvate in cytoplasm, then citric acid cycle, oxidative phosphorylation completes the cycle so that you have an efficient production of ATP. Once it is partially interfered with the respiratory chain by metformin, there is a reduction in the ATP anticipated. This is similar to something like your dietary deprivation, calorie restriction. This stimulates, whenever the ATP level is reduced, then it stimulates an enzyme called AMP kinase. When AMP kinase is stimulated in the liver, it restrains the liver. When AMP kinase is restrained, cyclic AMP is more, that restrains the effect of glucagon. So, to put in a nutshell, Metformin acts as the level of the liver. The mechanism, even though the final word has not been said, we have better understanding at the molecular level. It interferes with the production of glucose at the level of the mitochondria, and it is fairly safe compared to metformin. And once it does, it creates a situation as if there is a certain amount of calorie deprivation for the system to produce this often repeated AMP kinase. Once it is done, then what happens is it restrains the liver from producing extra glucose, and also it suppresses the glucagon effect in participating in gluconeogenesis.
Fantastic answer. I think me and Sunil both appreciate the way you developed the story of AMPK, the story of calorie mimetic. You know, we know today calorie mimetics are also the instruments for weight reduction. You said the calorie mimetic and calorie restricting drug. You also said about the way it works. And just to add few things which are probably conjectural, but evidence does exist. You know, today diabetes is not only metabolic disease, is a metabolic. You remember Professor Sanjeevi Moses
Absolutely.
Menki? Is a
Yeah,
metabolic cum vascular.
absolutely.
Metabolic cum vascular jada. Jada mean Hindi means more. So when you have metabolic cum vascular jada, the metformin is also a vascular drug. You know that today. Am I correct, Sunil? Metabolism is a vascular drug. So it's very
Yes,
important.
sir.
It takes care of hypertension, reduces. So it's a vascular drug. And so these are the issues. And also to stretch it, imagine little further, it is anti-aging, and diabetes is a function of aging. You know, so there are so many ways, but the main thing you have said, AMPK and its action as a calorie mimetic to retard the weight, and it's beautiful you have said. I think we have discussed everything. Now the most important question to Sunil. Sunil, you hinted at somebody having HbA1c of 6.3, and at 6.4 we diagnosed diabetes. So you give an hint, but Sunil, for the benefit of the audience, uh, you give the patient profile where the metformin should be introduced for the management of pre-diabetes. You know, it is indicated for everybody we have discussed now. But what group of patient profiles we will definitely use metformin, and that those patient profiles for the benefit of our uh, physicians who have joined us today. You gave one indication when the
Yes,
H1C
sir.
is compared to, yeah,
Yes, sir. So we have partially discussed this question already, but
yeah,
now let me bring it once again in a single answer.
yeah,
So now, any patient who is on the pathway of insulin resistance, like somebody who is obese or centrally obese, let us take those kind of patients. So we have a large number of patients in our country who may not be obese by BMI criteria, but they are centrally obese. They are insulin resistant. We are seeing so often when a sonography is done, you see the fatty changes in the liver.
absolutely,
Right.
fatty
This is very commonly we keep seeing such patients. Now, if in such a patient there is a family history of diabetes is already present, I saw a HbA1c 1 year ago. It was 5.8. Patient is already doing some effort. I repeated the test this year. HbA1c is now 6.3. What should I do? I need to start. And in such patients where we are seeing that already some progression is going on, we should not wait. We should now initiate pharmacotherapy like metformin. And in addition, there are a subset of patients who are very obviously insulin resistant, obese, having a lot of markers, very strong family history. Though guidelines say to wait for 6 months for lifestyle modification, but in such patients, already I can see that they had already so many years of insulin resistance, and that's how these things are happening now. So I would prefer to go with
கூப்பிடுறேம்மா
lifestyle modification and metformin on day one in such set of patients.
I think great answer. You know, I know it is. We discussed that it has to be used, maybe possibly in every case because diet is not enough. But the areas which Sunil highlighted are very important. Closer to diabetic range, FPG, PPG, and HbA1c. As you said, last year 5.8, today it is 6.3. How long to wait? How can we wait? Number two, conjunctive family history, visceral obesity, the NFLD, NAFLD, liver having fatty liver. You know, we have today. You know, somebody asked me, why do your government, you know, I work for the government, why do you advocate screening? So we have made these five principles. Why should you do screening? Why should you diagnose pre-diabetes at all? Number one, is it a public health problem? greatest public health problem. To prevent diabetes, pre-diabetes has to be diagnosed. Number two, is there a good screening test? No doubt. Fasting postpartum. Number three, do you have effective intervention? Yes, we have effective intervention in metformin. Others I'll discuss, and so what is the drawback of those? And fourth one, does it change the outcome? Yes, it changes the outcome not only of the hyperglycemia, as both my experts have said, they change the outcome of the CAD, of the vascular disease, and etc. And of the dyslipidemia. So it's a great answer, Sunil, and I think beautifully said. Now to complete the question, I want to ask you the second question, Sunil. Does early initiation of metformin, can it delay beta cell apoptosis, either directly or if not directly, at least indirectly? Does it prevent beta cell apoptosis?
So obviously, for beta cell apoptosis, we do not have any direct human data because it is not possible to measure beta cell mass as of now.
Yeah,
We can measure indirectly by some beta cell function, and that's what we can do at the most. Now, in any patient in whom we can add upon a strategy which can help in improving insulin sensitivity, obviously it is going to reduce the burden on beta cells. We understand the natural history of diabetes, and that's how finally patients, we know that by the time diabetes is diagnosed, 50% of the beta cell function is gone. Now, if we intervene far earlier, then logically, though we don't have a direct proof, but very much logical that with the help of both lifestyle modification and drugs like metformin, we can reduce beta cell apoptosis and prolong the beta cell survival.
I think great answer. I think I cannot agree more. And also through that, the glucotoxicity, beta cell life becoming prolonged, and also its effect on the coronary disease and the macrovascular disease. I think beautifully answered. Now I just asked Venki a very important question. We have discussed it, but your own intake, Dr. S. Venkatraman's call, his own personal call, how long will you wait before you start metformin in pre-diabetes? Venki, it's a very pointed question, personal question, but I would like to know from a physician like you, from a
Yeah.
diabetologist and endocrinologist like you, that how long will you wait?
Yeah. Before the answer, if you do not mind,
So,
I think
so Sunil
Mr.
said
Sunil
after
really
6
addressed. I think even though there is not conclusive evidence, the way we have understood the mechanism of action of metformin, because I was talking about the molecular level, it even has an effect on the GLP-1. So that's why when you give a DP4 inhibitor and metformin, the effect is additive. Speculating, it is speculative that even though we do not have evidence, we know that we do have a molecule which is beta cell trophic, probably through the GLP-1, even though the effect may be very, very trivial. That's number one. Number two, I mean, to quote, I think the RSDA guidelines have said if 6 months lifestyle modification you are not able to, the dysglycemia is not is progressing or not regressing certainly. But my own call is the moment I make a diagnosis of pre-diabetes, especially in somebody who's very lean and in whom I would be slightly hesitant at that stage to introduce metformin. Otherwise, overweight, obese, previous history has GDM, I straight away start them on metformin. This is what I do in my clinical practice, even though the guidelines are less aggressive. In fact, the ADA says BMI of 35 or 30, and then of course previous history of GDM. Some criteria have been given, PCOD, liver. I think already Professor Sunil has nicely mentioned the clinical instances, but I am slightly more aggressive in this particular aspect because we are convinced about this molecule. It's a wonder
I think
molecule, and
both of your answers have been great and a great indicator to the what our physicians must do. So I think I will not repeat it, but it is crystal clear, clear as daylight, that it's let us have a small break for a joke. Somebody said, what are the guidelines? Guidelines are like railway timetable. So trains can come earlier. I mean, who prevents it? Am I correct? Indigo goes earlier. It is so. I think beautifully we have said, and the we are. You must have got the letter. We have issued the letters to all of you that we are having the revision of the guideline. Bridge Makar has written, and one of the things I have suggested is to remove this 3 to 6 months. But let us see what the consensus will be. But fantastic answer, Sunil and Venkat. I want to tell both of this important point. I reviewed recently pre-diabetes and the use of metformin, and I reviewed all the literature because I have access to up to date and all that in Jipmap. And the meta-analysis, which I want to bring to notice, said that the use of metformin in pre-diabetes in the tier 2, tier 3 cities by GPs and CPs, in contradistinction to diabetos and endos, is abysmally low. It is between 0% to 17%. So I'm giving you fact. I have got evidence for that. I'll pass on that paper to you. So this was an eye opener for me. So I thought that there is lot of inertia among the physician not to start treatment, not even lifestyle. I mean, the metformin 0% to 17% highest in pre-diabetics. So I just want to spend 2 minutes or even 1.5 minutes, 1 minute. What should you do to spread this message uh, to the general population? In fact, one of my close colleagues said, what is most important from this webinar is what you should do to spread the message to dispel this inertia of not treating pre-diabetes. So Sunil first and Venki next. You have 30 seconds each because I'm very passionate that one of the outcome of this webinar must be that this must percolate down to the CPs and GPs.
Sir, one is the inertia comes from the physician side, as well as see there are many patients we understand in the country who don't want to start medication even for diabetes.
I
That is
fully
that is
agree with you.
that is that is
I cannot but
yes, sir.
agree. Many patients. You know, I had a patient who is a great guy. He's home minister's colleague. I know he had hypertension, Venki. I was treating it. The moment hypertension became little controlled, he stopped. You know, dyslipidemia, hypertension, metformin treatment cannot be stopped once it is normal. Treatment has to be continued. I told him, he did not. And lo and behold, he has a stroke today. Today I saw him with a stroke. So I cannot but agree with you that people have an aversion to take drugs. Fully agree with you.
Secondly, sir, one more thing that's a improvement side, because one is the awareness and information among the doctors about the role of metformin to be initiated for pre-diabetes. There was not a very clear-cut guideline. That is one thing, though ADA has a recommendation for their population, which is talking of a different BMI and different age. Obviously, age of less than 60 is too high for Indian population. We need a very
You have been
younger
agree.
age to.
I think Sunil, Venki, I heard Sunil I mean, I hear him many times. He had called me also to Indore. You know, I must tell you, I heard him on the NIDD. He was talking precision medicine, Venki. And you know, I heard him for the first time in precision medicine. After the lecture, I went to him. I said, you are as good in precision medicine. You talk about neonatal diabetes, temporary and power neonatal diabetes. What is genetic? How sulfonylurea to be used? Details which even I have not heard from Mohan or Radha, but Venkat Radha, who is the author of those two papers. So I think Venki, you are absolutely correct. The ADA guideline says less than 60 years because I do not know, they marry at 45, Venki, or they marry at 50. Their life begins at 60, so they're young. Number two, they say that I mean, you know, the data is so much way beyond us. So you are absolutely correct. And so the Indian guidelines must be uh, what is relevant to us. Yes, please continue.
Yeah.
And so lastly, that is what is a very good thing which I will appreciate, that which has happened, maybe whatever is the way, but now there has to be labeled approval for the drug. That's very important.
Yeah. We'll come to that now in a minute.
Yes, sir. So that is another big thing which has happened.
Yeah.
Absolutely.
We'll come to that.
I
Before
think,
that,
Professor
you have any?
Ashok, yeah, Ashok, what I thought was, I think this message in this sequence, I feel it should be conveyed to the clinicians across the country. Number one, pre-diabetes, the chances of getting converted to diabetes is 3 times more compared to somebody who has got normal glucose tolerance. Number one. Number two, the clinician in that particular patient has had the golden opportunity of identifying the pre-diabetic stage, because quite often we identify diagnose diabetes with the complications, as you just now mentioned. So this is a window of an opportunity, or a golden opportunity. Number two. Number three, we have got various molecules which have been proven to be effective. You have got troglodyazone, you have got metformin, you have got liraglutide, etc., whatever it is. But among them, to apply to a population, take into consideration everything, the efficacy, the cost effectiveness, the wealth of data, DPP, IDPP, etc., metformin scores. I think these three.
Venki, I cannot resist the. I read the article by David Nathan. You know David Nathan. He said
Yeah,
Lina, bioglitagen, the so many things have been tried. The nataglinide, acarbose, but you see, he says very clearly it has gone to ADA guideline. He said they reduce sugar, but they do not have the evidence of the cardiovascular benefit,
absolutely.
the lipid benefit, which is embedded in metformin. So he has said that he recommends metformin and the society they recommend metformin because, as you rightly said, these drugs can reduce glucose, but the CAD benefits are not embedded in a preventive dose. Lira might be having some leader trial, but it is embedded and most important, cost effective and no side effect. That's what side effect compared to placebo. That's what I think you beautifully you said that. Fantastic. My dear friends in the audience, now we have got another 27 minutes only. We'll be finishing earlier than 20 minutes. I just want you to kindly load your questions on the chat box or the QA box, and I request Srishti and my dear friend Dr. Shona to kindly get the questions and pass on to me either on phone or in my workshop so that we'll take up those questions from the audience. Now, the next question is very important, very important. Now, you know, that uh, it has been rightly said, as you really discussed just now, that the metformin can prevent type 2 diabetes related microvascular complications, and we just discussed about the coronary disease and dyslipidemia, etc. And it has been also, as you said, Sunil, that in our parlance the drugs are more cost effective than the lifestyle, because lifestyle will be very, that has been shown by Ramchandran also, IDPP study. He said it was very important. Now, we have discussed some targets. What are the other targets of metformin? Venki would like to announce. What are the other targets? We have discussed anti-aging, yeah, anti-lipid, anti-hypertensive, minimal reduction, and also things like the anti-insulin resistance, GLP-1 promoter, and things like that. Anything else you like to say about the
Yeah, a couple
metformin,
of
which we
things
have
I
not
think which
discussed
is
so?
very relevant in the context of what we are talking, the macrovascular disease. One is the markers like the
Yeah,
HSCRP and also the TPA. And in this context, I would like to make a very relevant note. Maybe people who are academically interested, just take that.
yeah,
I'll take 1.5 2 minutes, Professor Ashok, if you permit me.
yeah. Please.
There is a trial called BARI 2D, which is comparing insulin sensitizers with insulin providers. So metformin and Rosie were in one angle. We are not going to go into the greater details. But what the commentary about this BARI 2D post hoc analysis is, when they found out this PI1 level, the plasminogen activator inhibitor, that was favorably impacted by rosiglitazone and metformin only, not even with insulin. So
Great.
pi1 is responsible for the qualitative nature of the atherosclerotic plaque. See, a muscular plaque is less prone for rupture and migration of the muscle cells is inhibited, and a lipid-laden plaque is the hallmark of diabetic atherosclerotic cardiovascular disease. That's why you have the acute coronary syndrome, etc. Now, this tendency mediated by pi1 is favorably impacted. This is a very soft data, post-hoc analysis. What I'm trying to say is metformin, we have a lot of experience. We have learned something. We need to learn much more because it has got wonderful avenues which probably have been partially explored and the knowledge is started emanating. So
I think
inflammatory
very,
markers and pi1, TPA or other markers which are relevant in the context of cardiovascular disease.
I think great answer, Venki. And as Sunil rightly said, we have markers that are traditional, like the FPG, PPG, HbA1c. We have markers which are not so modern marker, but the modern markers center around the TPA, PAI. It also centers around the other markers which Ramchandran group had shown. So I think it's a great answer. Also other benefit I was mentioning, anti-cancer, at least 4 or 5 cancers it addresses. So there are a lot of benefits which metformin provides. I
Got
just wanted
microbiota also, sir.
got microbiota, great,
Yes.
broad microbiota. So it is great. And I think now I'll come to the
There's
last.
a recent paper on metformin effect on colonic malignancy. That they
Yeah.
have studied
Right.
that the local glucose absorption is being prevented, even though we do not talk about the interference of glucose absorption, the pharmacological doses. So, in this particular set of patients, it was there in diabetes care about 6 months, 1 year back.
Yeah.
I just thought I'd make
I
it.
think I saw that paper. Sunil, what Venki has done, they have a separate journal club and they have a group, exclusive group. They invite me all the time. So they read all the important papers in a month. And so that's why I think that's a great thing that countries should follow, Venki. I congratulate you for your diabetes journal club and absolutely happy to note that. Sunil, very practical question. Uh, in Indian scenario, generally, it will depend on the patient's body weight, etc. What is the type of metformin dose you will start and how will you continue?
Now, as far as the metformin dose is concerned, we understand that generally we can go because metformin is not going to cause any hypoglycemia, and we want to have a reasonably good drug level to cause an improvement in the insulin sensitivity. If we look at the US trial data, they had used metformin up to 1700 in terms of diabetes prevention, uh, and the pre-diabetes to diabetes conversion. And there are good number of Indian studies like we have few from Chennai also, which had shown that even 500 milligram BD may be a good dose of metformin for prevention of diabetes. So maybe 500 milligram twice a day, or those patients who tolerate well, who are comfortable, we can up titrate as well.
I think that's a great answer. The dose indicated is 500 milligram twice a day, if possible SR, if possible SR. People have also used for the low body weight and also having indication to start metformin immediately, 250 milligram twice a day. So that is the dose you use. Why I wanted to bring out this question, Venki and Sunil, is that in the DPP program in America and DPS program in Finland, the dose used was 850 milligram BD, as you are aware, 850. But in Indian Diabetes Prevention Program and the D-CLIP program which Mohan did, the dose indicated was maximum 500 milligram SR or even ordinary twice daily. So we as an ethnic uh, component of this particular game, we respond to a dose 5 milligram BD, and the answer is like you continue treatment for hypertension, like you continue treatment for the dyslipidemia. If indicated, the metformin treatment has to be continued because that will prevent prevent. I know anti-aging, giving senescence going away, living longer. So there are a lot of benefits why it should be continued. Now, now, can I just ask you what do you think about the recent the narrative of the DCGI's approval? I'll tell you what has happened. It happened about 1 month, 17 days back. And in that meeting, there is clear cut guideline. I was very happy to note they have said, as we have discussed the issue, that after a good trial of lifestyle, DCGI cannot say start from the day one. So the members said. Number two, they have given the all the indications that you have said, ethnicity which makes you more prone. I know everything that you said. The blood sugars closer to diagnosis of type 2. Number T, past history of pre-GDM or PCOS. Then the indications where you are in spite of whatever lifestyle, as Sunil said, HbA1c rising 5.8 to 6.3, FBG rising, PPBG rising. So the document that DCGI has given to my mind, is a great document. It's a great document, and it clearly says where to use it. And I'm very thankful that it absolutely said that it is to be used if you have high risk patients. MUST must use it. Others, you please consider because it is greatly beneficial. Now, how often have you found metformin intolerance, Sunil?
So metformin intolerance means most of the patients will have gastrointestinal intolerance. That is what is the issue.
Exactly.
And in our practice, I think that around 10%, 5 to 10% patients may be having intolerance to metformin. They have hyperdefecation and a lot of GI issues. We many time try to down titrate the metformin doses there, and some number of patients settle, but few patients never settle. And in such a small subgroup, then I consider other choice rather than metformin, but it will be a small number.
Yeah, I think as you rightly said, it does happen, but the intolerant is for a very, very small subset of patients, and where you can look for the other alternative, but it is negligible. Majority of the patients giving it after food, giving a SR preparation, these are the issues which takes care of the GI complications and takes care of it extremely well. In the meantime, can I ask me to kindly pass on the questions which have come from the audience? I'll take up two questions which has come from audience to me, which I will start first uh, asking the question. The person wants to know how often do you find vitamin B12 level being low? Is it clinically significant? One question has come from the audience, Venki.
Yeah, I think it has always been in the literature. Two things I will just share with the audience. I'm sure
Yeah,
nowadays we have the advantage of doing a mass trail checkup for everybody. Even diabetic patients, even though they are in a regular follow-up, they do the mass trail checkup. And most of the labs do the vitamin B12. Of course, we do give a supplementation, which is very high from the point of view of pharmacological doses. But you find the B12 level exceeding the upper limits of normal in a good number of patients who are already born on, with
exactly.
metformin. That's number one. Then number two, there has been some elegant explanation. For example, when you have a low B12 level along with metformin, one obvious explanation, as evidenced by the literature, is the interfering with the absorption, or I mean the production of the absorption. Number two, increased utilization. If something is better utilized, the serum level is low. So there are got some, in fact, USV has shared that data with me. There are some soft data to suggest that metformin facilitates the utilization of B12. So just because the B12 level is less, the cause and effect of its having an impact on the absorption or the production is less, it's better utilization. Anyway, that's a soft data in a lighter vein I thought I'll share with you. But I'm sure the B12 picture is slightly blown up. Certainly in situations wherein the B12 level is very less, which in our practice I feel is very low, because we have the opportunity of doing a master checkup for a good number of patients, and patients who have been on even with oral B12 therapy, even though it's very poorly absorbed,
Yeah,
even
yeah,
with oral B12, we find the levels to be quite significant enough, quite often exceeding the 950 nonogram or picogram. I think it's PG
yeah.
picogram that is exceeding. So keep it in the back of the mind, but never get carried away by the literature that it is too toxic with respect to, I mean, too detrimental to B12 metabolism. That's my knowledge as well as the experience. I would
I
like
think
to.
I think I think I fully agree with you. I'm yet to see very significant reduction, except in about 5% of the patient brought out, not because of anemia, but because of they go for a thyrocare multi checkup or a my hospital master checkup. They bring it out, and also I have found, Sunil, that many of our patients on a routine checkup, diabetics, they have found the B12 is 2000 and above. Well, as you said, normal. So I asked somebody who works in this from CMC Belur, Alok Srivastava. He said, sir, it does not matter. So, I mean, I do agree. There's a small fear. The questioner is quite correct. It can occur, but it's not very detrimental. So I'll go through another five questions before we take up the last question. Now, the question asked by Anshul Singhal from Bhilai. uh, Metformin has beyond glycemic benefits to offer, uh, and lifestyle intervention is difficult to monitor. We have learned today, so that is why he says metformin is to be initiated soon, as early as possible. I think Anshul, you have really understood what we discussed today, or you may be having this pre-knowledge. What you have said is correct. Metformin has lot of benefits beyond glycemic control alone, and lifestyle intervention is not only monitoring, offering it, monitoring it, finding the outcome is very difficult. So metformin has to be initiated early. The second question is untimely weight loss in overweight to obese patients. Will it be the best goal to achieve in order to reduce complications associated with prediabetes? I think it's a very thoughtful question. We sometimes find, Venki and Sunil, we have found many patients who have a gross weight loss. We have seen whether it is a keto, whether it is a real, as Sunil rightly said, there are few enthusiasts who really bring down their weight. So the questioner has asked a very significant question in a pre-diabetic, whether ultimately a severe weight loss in an overweight patients, will it be detrimental?
You want me to
Somebody
take up the
having a great.
question? Yeah. So I'll start
Yeah,
first and
go ahead.
then I would like to listen from Sunil. See, if you look at the evidences in the DPP original trial, there is a weight loss of, I think, 3.1 kg, if I remember right. And the conversion, the prevention of diabetes was linked to the weight loss. Whereas in the Indian DPP, wherein a lower dose was used, even though the conversion was 28%, I mean, the effect was 28%, there is no appreciable weight loss in the metformin. Yes, we do come across weight loss, and that is not difficult to explain because we have discussed how it acts. Since it acts something like a nutrition depleter with the level of production of the ATP. So certainly at the level of the metabolism, it is taken care of. Maybe in some people, the metabolism is so fine-tuned that the weight loss is much, much more. This is a very, very small subset of diabetic patients, wherein probably one can be cautious enough, maybe de-escalate or even give a, for example, the weight loss is so severe, if no other cause for weight loss, because mind you, a diabetic patient losing a weight
Yeah.
loss, even though metformin is on board, I think that should be in the last in the priority list of the clinical consideration, because there are so many other possible causes, maybe an associated malignancy, severe neuropathy, etc., have to be taken care of, to be kept at the back of the mind. Of course, metformin does complete the list in a small subset of patients.
Yeah, I think metformin basically is weight neutral, and the weight loss is very minimal, even though it has a calorie mimetic function. So it is very beautifully said. And you know that, and if you find, as you rightly think, that if you find the metformin is not acceptable and you find that the weight loss is abnormally high, you look for other conditions like severe neuropathy with cachexia, or look for some other cause. There's so many weight losing diabetes, so many things are there. And if you want to think, then you can also take recourse to LSI, lifestyle interventions, along with the metformin to keep the weight neutral. But metformin per se will not produce a very significant weight loss. And it is weight neutral. And both, you quoted the IDPP, I'm quoting also IDPP and declip. Declip showed 32% conversion rate. I mean, 32%. And I want to bring you a notice. Today, one new information has come in the diabetes care, which said the NNT, number needed to treat for pre-diabetes to diabetes prevention, is only 4 and 7. If you treat 4 for 1 year and 7 for 3 years, you find the conversion rate is very into two different studies. So it's a number needed to treat is much lower. I'm very happy about it. Sunil, I saw it in the diabetes care. The number NNT for preventing pre-diabetes going to diabetes is 4 is to 1 or 7 is to 1, which is a great news. So I'm very happy. The next question is very tricky. OGTT. For screening you have done. We don't do OGTT, doctor. I don't know the author of this question. Name is not here. But he says how to interpret the first hour data and 1.5 hour data. So, Sunil?
Yeah, so basically nowadays, see, uh, when we are going to do a OGTT, we need to do 0 hour and 2 hour,
Yeah, that's
and
what you
that's
do.
what we are
Exactly.
going to interpret, and that's where is the definition of the abnormality lies. Now, earlier we used to do 30-minute, 60-minute, 90-minute samples also, which are really not required. 1 hour data we are doing only in pregnancy, that too by the ADA criteria or IADPSG criteria. Now, suppose somebody has done 30-minute glucose or 1 hour glucose, then as such we have no cutoff. As such, we have no recommendation for that. Though we have, if they have done some insulin or C peptide at 30 minutes, then we can have an indirect measurement of beta cell function by measuring insulin glucose delta at that point of time. And sometimes suppose we have done that measurement and it is very high, again it will be unphysiological. But my comment will be, if we are doing a OGTT, a good practice will be to look at the fasting and 2 hour, and then based on the available data label the patient.
I think that's true. That's true. I mean, only in pregnancy, the first hour data has been correlated to becoming diabetic after the delivery. The child of the baby has been correlated to that. But in normal situation, 0 1 2 hours. But there are some studies, so Sunil, I mean, I heard it from him because, Mohan was presenting data. He does everything. Half one, I think he has a lot of data on 1 hour. Now, one of the things that is said in that particular discussion, that 1 hour data, the closer it is to high, as you were discussing, same thing as you said, as the closer to 2 hour data, closer to 1 hour normal data, it becomes more prone to become pre-diabetic. I think exactly the same thing as you had discussed. I'll take up one more question, and I promise that other question answers will send by the WhatsApp, because every good thing has to come to an end. So, and I understand that my experts are working the whole day. Now, the question is very tricky. That's why I want to take this last question. Other questions, I promise, through Dr. Sona and through USB, I'll send the answers through WhatsApp. The question is, Sunil and Venki, the question is very intelligent. You are accepting 140 milligram in the postprandial and saying that it will not happen your endothelium. Very question. I think as very young doctor, sir, why don't you think in fasting 140 will damage the endothelium? I know, very interesting question, no? Maybe have you understood? We say in the postprandial, 140 to 199 will affect the endothelium. That is the concept, no? It PPG. Why don't you say in the fasting, you are taking fasting as 126? Why don't you think even 140? I mean, why in the fasting state? Why 126? Why not 140? Because you are saying 140 is endothelial damager. So why do you say fasting 126? I think it's an intelligent question. I like the question. Have I made myself clear about the question? I'll read it again, sir. We accept 140 milligram deciliter as it don't cause any endothelial damage in the IGT. But for the fasting, we say it should be 100 or 125. Why in a fasting state up to 140 we cannot relax? Am I clear myself, Sunil? Is the question clear?
Yeah, what I have understood, Ashok,
Yeah.
is come to the fasting, why this 126? Because when the fasting was reduced across the globe to 126, there is hue and cry. Whether it's the pharma industry that is being promoted by the vested interest. No, it is because of the risk of retinopathy starts when the fasting is more than
That,
126 and
that
the
is the
HbA is more than 6.5. That is number one. And
that is the
number two,
diagnostic part.
when you do a GTT, I think the cutoff levels of less than 125 and the less than 140 is the normal pattern. That is, at the end of 2 hours following a 75-gram glucose load, if the level is going to be 140, then that is normal glucose tolerance. In fact, we are using postprandial and post glucose load synonymously. Probably it's a glucose load that is required for the IGT. Now, having said that, with a fasting of 98, 110, 120, if you have a post glucose load or a postprandial of 150, 160, then to metabolize this extra amount of glucose generates so much of work by the tissues. So there is so much of oxidant generated which exceeds the quenching capacity of antioxidant. That is how the problem starts. So the macrovascular disease link is because, in fact, there is a very, very good debate in one of the IDF. They compared the results of ACCARD Advance and VADT with the EMPERAG outcome. So, Satar, no, from UK, he gave a beautiful answer. See, in ACCARD Advance and VADT, what you did was, whatever the extra glucose, you try to push it to the cells. Once you push it to the cells beyond a particular level, that's a strain, ER strain, etc., all those blah blah. But in EMPA, what happened is the extra glucose was thrown in the urine. So what I mean is why I'm quoting this is when you metabolize that extra substrate, then that results in endothelial dysfunction. At the level of fasting 140, it is much more advanced. It is a frank diabetic state, whereas we are talking about a normal fasting or a IFG with an impaired post glucose typically or a postprandial, which is where the endothelial dysfunction starts.
I think it's a brilliant answer. I'll give a very simple answer, Vicky. I went to a conference long back, about 8 years back. It was held in Denmark. And the only thing I learned from the conference, the dear questioner, please watch my words. Only thing I learned, the lower that you can tolerate and you will not fall down is the lower the better. If you look at the longevity data, if you look at the diabetes complication free data, if you look at the point of view of mental alertness, whatever memory, diabetes type 3 not occurring, of the plex not occurring, the entire conference was centered around the lower is better. So I would suggest, Dr. Saab, what Venki said is absolutely truth. But please remember, now we load it. It was 140 earlier when we were students. Now it has come down to 126. It has come down to 110 and 100. The whole idea possibly, one is what he said rightly, that relationship to the retinal complication, which is the hallmark, the fact of the matter for giving the classification and the diagnostic values. At the same time, I think fasting 140 will be high. The lower is better. Let us stick to that. Dear friends, I have got exactly 9 minutes left. I leave behind 5 minutes for the organizers today. Uh, it's my great pleasure and honor to thank both my experts. Venki, it is not superfluous. Sunil, it is from the very core of my heart, and I'm echoing the feelings that the people in the audience have. They have really appreciated my entire WhatsApp is full with the appreciation. And it is great webinar. The things you have discussed are clinical and practical, and the knowledge you have given is absolutely fabulous. Dear friends, I will say that we have in our armamentarium a drug which is known for its efficacy, and not only glycemic, efficacy from glycemic to vascular to cancer to the gut microbiota to lipid friendliness, hypertension, whatnot, which is safe, absolutely safe. I know there is centered around safety and very cost effective. And and there is data on this from at least 5 international studies, which has shown that this is beneficial. It can either prevent, if not prevent, at least delay the onset of type 2 diabetes between 3 and 12 years and at least 8 years. That is the data which has been published. So, therefore, today I have coined the term that not using the drug is no more acceptable. It's an imperative choice. Imperative choice. I don't want to give any strong analysis or strong comparison. Please excuse me if I'm telling strong comparison. We had two American presidents. One American president died of tuberculosis in 1941 because that time the streptomycin was not found. Am I correct, Sunil? He died of tuberculosis. Drug was available. But the other American president died of hypertension. While remember our studies, you are much younger to me, Sunil and Venki. There are two people, Pickering and Platt. You know them, Pickering and Platt. Pickering and Platt, you remember, Venki? They were arguing whether Sunil is a very, very big doctor, so he should have more blood pressure. And Platt used to say, no, it is not individualized. So Pickering and Platt were fighting whether BP should be treated or not treated. And Roosevelt had a BP of 190 by 120, 130, and he had a cerebral hemorrhage. So I don't want to give strong examples, strong comparison. But my dear friends, from our side, the message is the choice is imperative. If you have a pre-diabetes, you can use lifestyle at the beginning, but you have to add metformin, which is the most approved drug, and compared to other drugs, has stood out at the molecule of the decade for pre-diabetes because of its multiple other benefits like CAD benefit, the lipid benefit, hypertension benefit. Use it, and that will give you that the choice is imperative. Not using it is no more acceptable. Dear friends, at this point, I thank USB on my behalf of Professor Venkatraman and my very dear friend Professor Sunil Jain, US for giving up this opportunity and this evening. Now over to the organizers for their last minute job, and then we'll close it. Over to Sona and over to whoever takes it over.
Thank you, Professor Ashok. Thanks for the opportunity,
Yeah,
USV, and thanks for doing a program with Sunil.
Thank you. Thank you,
you
sir.
are my
Thank you.
first
Thank you.
choice.
It was a great learning with you.
Great, Rani. Thank you. Sona, will you give your comments and close it, or who is coming? Or Monal will close it?